So thanks very much, everybody, for coming on really what I think is the first night of winter. It's very cool out there. And thanks very much to Aware for the opportunity to speak to you this evening. My name is Martha. I work with the Depression Neurobiology Research Group. We're based here and also at Trinity College. So I'll tell you a little bit about our work. We'll talk a bit about depression and about relapse and the area of relapse prevention. And then I'll tell you about some pretty exciting new research that's going on here in St. Patrick's. And I'm happy to take any questions afterwards. So I suppose just to put this all in context before we get into the science of it, when you Google depression in Ireland, you get the first image that comes up is this one of Ireland's sovereign debt, which obviously is pretty depressing for everyone. But there's also lots of positive imagery that comes up there as well. And I suppose just to put this in context, as everybody is aware and why we're here this evening, is that about 300,000 people in Ireland have clinical depression at any time. So that's about 1 in every 11 or 12 people. So all of us know somebody, even if our own family is not directly affected. It's also the most costly brain disorder in Europe. So lost days of productivity and lost quality of life due to depression costs about 1% of the total European economy, which is about 118 billion euros a year. And we're going to be talking a lot about the science of depression this evening, but I suppose aside from the science, the reason behind the research is that for everybody, the ultimate aim is recovery. And when we talk about recovery, we're not just talking about symptoms going away, but about moving beyond the effects of mental illness. And as the original definition goes, development of new meaning and purpose in one's life beyond the effects of mental illness. So when we talk about relapse prevention, it's really about aiming to get that sustained period of wellness that gives somebody time and space to really recover from mental illness. Unfortunately, as we all know, and anyone that's following Ireland's Rugby World Cup journey will know, recovery from any physical illness or injury is never straightforward, and it's the same for any mental health problem. The journey can be long and difficult. Unfortunately, as we know with depression, over half of people who have one episode are likely to have another episode. And because it is a chronic condition, most people in their lifetime will have between 5 and 9 episodes. So it is now considered to be what's called a relapsing remitting condition. This illustrates, I suppose, some of the pathways that people can experience once they've had an episode of depression. So when we look at the line for response at X, that's somebody who's starting to recover from their symptoms and reach a level of an improved quality of life after depression. When we look at the X for remission, that's somebody who's really returned to their normal quality of life, maybe back at work, back doing the school run, doing all the normal activities of life. But unfortunately for some people that doesn't last long, and when somebody returns into depressive symptoms within 6 months, we call that relapse. For other people, they can go on and remain well for a longer period of time. And if depression returns after 6 months, we call that recurrence. So really what we're talking about tonight is trying to improve the quality of life for people once they've just recovered from an episode of depression, and really allow people to have that sustained period of wellness that results in true recovery. And I suppose it's appropriate that we're here in St. Patrick's Hospital. We had a conference last week about empowering recovery. And whenever, I suppose, we think of the founder of this hospital, who, I suppose, 260 years ago now gave all his money to found the first caring institution for people with mental health, my favourite quote of his is, "May you live all the days of your life." And I suppose that's really what we're aiming for when we're talking about relapse prevention. It's about that improved quality of life and making sure that there aren't days lost to people experiencing symptoms of depression. So just to talk a little bit about our team, that's us looking very solemn there. Some of my colleagues are here this evening and happy to take questions as well. If anyone's interested in the work of our team, there's more information on the Trinity School of Medicine website. We're funded by the Health Research Board, and so we are directly funded by taxpayers' money and European money, which we're very conscious of. We're also funded by the Institute of Neuroscience of the United States. Our principal investigator is Professor McLaughlin, and we're lucky to collaborate with professors in other institutions such as UCD and in our home lab in the Institute of Neuroscience. So the work of our team focuses on the biology of depression, so the underlying, I suppose, the science of what's happening when somebody's experiencing depression and ways that we can manipulate that to provide better treatments. And so we use all of the tools of research at our disposal to do that. So some of our studies have focused on animal models of depression and trying to utilise information from those studies to apply those to finding new treatments for people with depression. We do epidemiological research, which is research that compares populations maybe with and without depression to try to understand the basis for that. We do systematic reviews, which is a way of aggregating results of lots of different trials. And what we're mainly going to be focusing on tonight, we look at clinical trials and biomarker studies as well. So in terms of the background to our study that we're going to talk about this evening, as I've discussed, we all know that depression is a very common illness and unfortunately very highly recurrent. Over half of people with depression don't respond to the first therapy that they try. And unfortunately, 1/3 will then fail to respond to multiple therapies. And so they have what's called treatment-resistant depression. There is a very effective treatment available for people with treatment-resistant depression called electroconvulsive therapy, which I'll talk a little bit about. And some of you may be familiar with the treatment. And 40 to 70% of people who have treatment-resistant depression will respond to electroconvulsive therapy. But unfortunately, even though we have good treatments to help people get well, although they're not ideal, what we're not good at is helping people to stay well and to have that true recovery from an episode of depression. So unfortunately, no matter what the treatment, for people with severe depression, once they finally become well, unfortunately there's a very high relapse rate within the first 6 months, which is really the crucial period once somebody has become well. And that's in and around 40%, regardless of what treatment has helped them to become well, which is really unacceptable, I suppose, when we consider the impact on a person, their family, and maybe their supportive friends and their community in general. If somebody spent a long time trying to get well from depression and finally gets well, to have a 40% risk of being back in the same situation within 6 months is really unacceptable. So just a little aside about electroconvulsive therapy, for anyone not familiar with it, it's a safe and effective treatment for serious mental health problems, so depression, mania and catatonia mainly. The effect size that you see listed there is a way of measuring in medical science how effective a treatment is. And the effect size of 0.8 is something that really we rarely see in psychiatry. It's very significantly effective and actually more effective than drug treatment for people who have the correct indications. So every year in Ireland, about 200 to 250 people have electroconvulsive therapy, and around the world about 1.4 million have the treatment every year, which was the last estimate. So just going back to the issue of relapse prevention in depression, we know that taking antidepressants once you have become well and continuing to take the antidepressant that has helped someone to become well reduces the odds of them relapsing by 70%. However, as I said, the relapse rates remain unacceptably high. So the protection that you get from continuing to take an antidepressant is limited. We don't exactly know what's the optimal length of time that anyone needs to take an antidepressant once they've become well. So it's possible that there's some unnecessary drug exposure and unnecessary expenditure and inconvenience for people in continuing to take a medication when we don't know what the optimal duration is. So it's clear that this is a really urgent clinical need that we don't have good answers for as to how we can help people to stay well. So looking at some of the current approaches to helping people stay well, as we know, most antidepressants developed sort of by chance, so serendipitously. So the major classes of antidepressants were discovered by chance. They all work to increase the availability of some brain messengers called serotonin and noradrenaline. And what most antidepressants do is work to increase the amount of those messengers that's available in the space between brain nerve cells to communicate. Unfortunately, for most antidepressants, there's what we call a latency period. So even once you get up to a therapeutic dose, there's a period of a few weeks of waiting for the medications to take effect. And it's clear that that's not really a good enough treatment. So there's obviously a need for antidepressants that are stronger, as in they'll work for more people, and that are faster, so we don't have that waiting around period. And this slide is really to completely bamboozle you and just to illustrate how many pathways there are currently being investigated as to how we could find what would be a better treatment for depression. And there's an infinite number of research projects in trying to find a new treatment for depression. And I suppose the one that we're going to focus on mainly today is highlighted in red, and that's the glutamate system. But just to be aware, there are lots of other research projects going on in different areas. So one drug that acts on the glutamate system, which is a brain messenger system similar to the serotonin system, is called ketamine. And you might be familiar with this, you might have heard of it in news reports or on the web, because it is known as a street drug. Actually, it's been used for many decades in children's medicine and in veterinary medicine as both a painkiller and an anaesthetic. So it's known to be very safe when given under medical supervision, but unfortunately it is also a drug of abuse. When it's abused, it does have significant harmful potential. More recently, it's found new uses in emergency departments, so for pain control and also in chronic pain clinics. So looking at how the background to this trial came about, essentially what was happening was that ketamine was being used as an anaesthetic, and what was found was that people who were having surgery who were also depressed maybe woke up from their anaesthetic feeling a bit better than they had beforehand. And this didn't seem to be anything related to the treatment, but rather it was thought that this was something to do with ketamine. We know that ketamine works on the glutamate system, and there had recently been links between depression and the glutamate system. And so it was thought, well, why not investigate ketamine as a possible antidepressant? And that's what was done. So over the last 5 or 6 years, there have been a number of clinical trials of ketamine as an antidepressant. So initially what was done is that people who were experiencing acute depression were given infusions of ketamine at what's called a sub-anaesthetic dose, so a very low dose of the drug. The effects were absolutely remarkable. So the graph that's illustrated there just shows that the line in red is people who've received ketamine, and the line in blue is people who've received a placebo drug. Usually with a very effective antidepressant, you might expect after a couple of weeks to see some separation between the two lines. But the graph here is actually in minutes. So what you're seeing is that within hours there was a dramatic reduction in the level of core depressive symptoms experienced by people once they had an infusion of ketamine. And this was something that we'd never seen before with any antidepressant, something really remarkable, really novel. So 70% of people who had acute depression responded to ketamine when they were given it in clinical trials at a low dose. But unfortunately, the effect, as you can see there, the lines get closer together after a couple of days, so the effect does tend to wear off. It's thought that this antidepressant effect occurs through what's called neuroplasticity pathways, which I'll talk about in a minute. And it's known that repeated infusions of ketamine are safe for people in the general population and for people with a whole range of mental health problems. So just to take an aside for a minute and talk about neuroplasticity, this is probably the most exciting development in psychiatry over the last 10 years. So the discovery that the brain is constantly changing pathways and developing and basically learning how to do new things is called neuroplasticity. So it's the process of change in the connections between brain nerve cells. And before this, it was thought that really your brain was static and it doesn't tend to change. But as we now know, when you learn a new instrument, when you learn a new language, or when you have a major life event, there can be changes in the way that your nerve cells relate to each other, and you can form new pathways. And anyone who's a Star Trek fan will know that Spock had this remarkable ability. At the time, it was thought to be really sci-fi and something that was really improbable. But we now know that everybody has this ability. So we're essentially all Vulcans. This is called a forest plot, and it's a way of synthesizing the results of many different clinical trials. So each of the dots on a line represents one clinical trial, and then they're aggregated together into larger dots and smaller lines. And this is just to illustrate, so I'll just highlight some of these findings for your attention. So just to show you the effect sizes for ketamine when given to people with acute depression. And again, these effect sizes are really remarkable. So the aggregated results of these clinical trials is incredibly promising for ketamine as an antidepressant. It's given intravenously at the moment, but an intranasal form, which means it's inhaled through the nose, is about to become available as well. So I suppose just recapping on what we've covered to date, we talked about depression as a chronic illness and the issue of relapse as a huge debilitator for people with depression, for their families, for their communities, and how we don't have effective treatments for this. And so that's basically a huge unmet clinical need. We've also talked about the possibility of ketamine as being a new, novel antidepressant with really remarkable effects. And so that then begs the question, could ketamine have any potential role in relapse prevention in depression? When a question like this arises in research, the best way to ascertain whether this is useful or not is to do a clinical trial. But before you do a definitive clinical trial, it's important to do some exploratory work, and so do a pilot clinical trial. And that's essentially what we're doing here in St. Patrick's. So based on a health research award from the Health Research Board, so running over the next 2.5 years, we're doing a trial called the Keep Well study. And the aim of the study is very simple. It's to see whether or not ketamine could have a role in relapse prevention for people with depression. And so all the information that we'll go through tonight is available on our leaflets and also available on our website. So this is our long-winded objective, but essentially the objective of the study is to run a high-quality scientific trial to see whether there's any potential role for ketamine as an antidepressant in relapse prevention. So we're running what's called a randomized, controlled, blinded pilot trial of ketamine versus an active placebo, which I'll talk about in a moment, for 4 weeks following successful ECT. And this will inform then a future definitive trial. So anyone who's familiar with research or clinical trials will know that clinical trials take place in various phases. And so before even though we know ketamine is a very effective drug, it's been used for many decades, this is essentially exploratory work. So nobody has ever thought of using ketamine for relapse prevention before. So while it is very novel and exciting, it's also important to remember that it is an exploratory study. So as with all projects that are funded by the Health Research Board, you want to get maximum bang for your buck. So there are a number of different projects involved in the study. Tonight we'll be focusing mainly on depression and ECT and ketamine and relapse prevention. But just for your information, there are lots of other studies happening at the same time within our team and within other teams to do with various things such as early life stress and epigenetic changes and any possible biomarkers for depression in response to treatment. So I'll talk briefly about the design of the study. We'll recap on all this, so don't worry if you're a bit bamboozled. So the study takes place in 2 phases. In the first phase, we'll invite patients with depression who've been referred for ECT and are suitable for the study. We'll do a range of memory questionnaires with them, a range of mood questionnaires, and they'll be monitored weekly to see if they're responding to the treatment. We'll also then compare the results of their questionnaires, whether it's mood or memory questionnaires, with a group of healthy people from the general population. People then who've been monitored weekly for response to ECT, who become well with ECT, will be invited to take part, if they wish, in the randomised controlled clinical trial. And in that situation, they'll be allocated by chance on a 1-to-1 basis to receive either 4 infusions of ketamine or 4 infusions of a placebo drug called midazolam. So once that randomised treatment phase has concluded, we'll then follow people up for 6 months. And during this period, we don't know who's received ketamine or who's received midazolam, and we're following people up to see how their mood continues, whether they remain well. And at the very end of the trial, we do what's called unblinding, where we lift the curtain and basically assess who did better, the group who got ketamine or the group who got midazolam. And that's a question that we don't know the answer to as we go along, so it's important that we're seeing everybody the same way. So just to recap on some of the important aspects of the trial, it is a pilot trial, and that means that it's important, I suppose, that we run it to a very high standard. We're assessing things like whether it's feasible for people to travel to the clinics, whether it's comfortable for people, is there any way we can improve it for people. Randomisation means that you have a 1-to-1 chance of being allocated to the ketamine group or to the midazolam group, and that's completely random. Placebo-controlled means that we've designed the 2 treatments to be as similar as possible to each other. So some of the effects that people would have from receiving an infusion of midazolam would be the same as some of the effects you might expect if somebody's received an infusion of ketamine. So essentially in the clinic, it's important that we don't know who's received what drug. Also, it's important that when people are coming to the clinic and they're having maybe blood tests and they're having infusions and they're meeting our researchers, some of whom are here tonight, that might result in a placebo effect itself. So that might be supportive and it could cause people to hopefully remain more well. So we control for that by also having people in a group who are not receiving ketamine and are receiving the placebo drug. Blinding means that ourselves as researchers and the patients themselves don't know whether they've received ketamine or midazolam. So the only person that actually knows is the anaesthetist who's administering the treatment. And all of us doing assessments don't know which group anyone is in. And that's also called allocation concealment. So just to recap really on the design of the trial so far. So people who have depression, who are inpatients at St. Patrick's and are referred for electroconvulsive therapy, if they're eligible and wish to take part, they're screened. We do a range of memory assessments and mood assessments. And then they're assessed weekly during their treatment to see how they fare. Hopefully they'll respond to the treatment and become well. And once they're then well, they're invited to take part in the randomised control trial. And at that stage, they'll be allocated on a random basis in a 1-to-1 ratio to receive either 4 infusions of ketamine or 4 infusions of midazolam. Once that's finished, we then follow them up regularly over 6 months to see how people do. And at the very end, we compare the 2 groups. This is called a consort diagram. You may have seen these before, and this basically outlines what our expected figures are. So based on the activity of our ECT department, over a 16-month recruitment period, we expect 170 people to be referred for ECT. That's bearing in mind that St Patrick's does in and around 40% of Ireland's ECT. We hope to recruit 78 people to the study and then to have at least 47 responders to ECT. We'll keep going until we have 40 people who may consent to be randomised to either ketamine or midazolam, and then they'll be allocated to their groups, will receive their treatment, and they'll be followed up over 6 months. And then at the end of that, we assess who will do better. So who can take part in the study? Obviously, it's extremely important for all of us to protect any vulnerable people from being involved in research. So there's a whole range of exclusion criteria that unfortunately mean we can't invite everyone to take part in the study. So what's called our eligibility criteria, or the criteria that decide who should and shouldn't take part, are quite strict, and I can't go through them all here. Essentially, for the first phase of the trial, we'll be inviting anyone over the age of 18 who has unipolar depression, so has no history of any bipolar disorder, and is an inpatient who's been referred for ECT to take part. They also obviously have to have a minimum severity of depression and have no, memory impairment that would mean that they wouldn't be able to provide consent. Obviously, taking part in the trial is completely voluntary, and anyone at any stage can remove their consent to take part in the trial. In terms of the infusion phase, so these are all people who are now well, who've received a course of at least 5 ECTs and have achieved at least response criteria. We hope that everyone would remit with ECT, which means they would become completely well, but also people who've responded and may still have some symptoms of depression can also take part. They must have a nominated adult who can stay with them and also have no cognitive impairment and be able to provide valid consent. And again, participation is obviously completely voluntary. So we'll talk a little bit about the randomised treatment phase. The trial is what's called a real-world or a pragmatic clinical trial, and no more than the MTV show. It means that essentially real life continues while somebody takes part in the trial. So everybody continues to take their regular medication, to see their regular counsellor, psychotherapist or doctor, or do any programme that they would generally be doing. All the people taking part in the randomised treatment phase are people who were depressed and became well with ECT. They've been randomised allocated in a 1-to-1 ratio to receive 4 weeks of either ketamine or midazolam at sub-anaesthetic doses. It's important, for the scientific quality to note that the randomisation of the patients has been done at another centre, so it's done by our colleagues in UCD. People have their first treatment infusion within 2 weeks of finishing ECT, and then for the other infusions they travel as outpatients, so they could be coming up from home from wherever they want to travel from. The infusion itself takes 40 minutes, but we're monitoring people for a total of 4 hours during the clinics. So we're monitoring a raft of physical health measures, psychiatric health measures, and any side effects that people may experience using a range of validated scales. Also, it's important that somebody would have a nominated adult with them for 24 hours, and we contact them afterwards then to see how they're doing. As I said, we do a range of memory questionnaires. So these are standard memory questionnaires that are done as part of most research, and we're also doing a range of tests of higher brain function. So we do those at baseline when somebody has initially been referred for ECT, when they finish ECT, at the end of their treatment phase, and then at various points in their follow-up as well. As I said, we're following people up for 6 months after ECT, so we see them for full reviews at 6, 8, 12 and 20 weeks, and then at week 26 we do all of that, and again we do their memory questionnaires. So in terms of the trial progress, recruitment started in April of 2015, and our numbers have largely been as we would have expected. For a pilot trial, all the information that we gather is useful. So whether it's that people are not eligible because our criteria are too strict, or that people are not able to attend because it's too far for them, all of that information is useful for us. So far we've had 49 referrals, of whom 16 have been eligible and 10 have participated in the phase 1, of whom 3 are continuing the randomised treatment phase and follow-up. So it's useful for us to know who can and can't take part, what the difficulties are for people in taking part, how we can make it more comfortable for people. We have found as the trial has been progressing that unfortunately, obviously we can't invite everyone to take part. But because of the level of interest in the trial, we've set up a sister trial which will be running shortly. So we've recently received approval for this trial, and we'll be starting recruitment within the next couple of weeks. And this is called the Kindred study. And we're able to open this out to a wider group who also need strategies for relapse prevention. So for people with recurrent depressive disorder who are inpatients at St Patrick's and who are having treatments other than ECT, they'll be invited to take part in the Kindred study. And I suppose because this is quite a novel and innovative way to look at relapse prevention, it's not known what's the best way to give ketamine. So what we're doing is assessing whether it's best to give it once weekly or whether it's best to give it once every 2 weeks. And so we have that in the second trial. People will be receiving 4 infusions, but once every 2 weeks instead of every week. They'll also have a 6-month follow-up. So I suppose on my own behalf and on behalf of all my team, we just want to sincerely thank everyone who's taken part in our research to date. St Patrick's Mental Health Services is our legal sponsor, and our funding is from the Health Research Board, so all of you as taxpayers are funding this. And also we'd like to thank the support that we've received from the various departments that are helping us with the research within St Patrick's. Some of you may have received a leaflet on the way in. We are looking for people to take part in the study who are healthy volunteers who also have no history of mental health problems. And it's really important to be able to, I suppose, ascertain whether there are any possible biomarkers for depression, and we can do that by looking at blood samples of people who are depressed when they're well, and also people from the general population who've never had depression. So if you're looking for any more information on the study, there's an email there that you can email into, or if you think you know somebody who might be interested, you could pass the information on to them. Thanks very much for your attention. So I think we'll do questions and answers.